Good morning, everyone. Welcome to our 19th annual release of the Medicaid Budget Survey. This report started many years ago as a way to track how states were cutting their programs in response to the economic downturn back in 2001. Well, Medicaid programs have come a long way since that time, and we're certainly in this report tracking a lot more than program restrictions. The report really provides a comprehensive look across state Medicaid programs to capture the huge array of policy initiatives that are underway in the states. Each year, we piece together how programs are adapting to meet prevailing state and federal budget and policy priorities, and how these changes are affecting the over 70 million people who are enrolled in the program. Before we turn to the business of the day and the findings from the report, I just want to recognize and thank so many of the people who make the report possible. First, I want to thank NAMD for their support, and all of the Medicaid directors, as well as all of their staff who helped to complete the survey. And of course, a special thank you to the 3 Medicaid directors who are with us today on the panel. I also want to really thank our partners at HMA, Kathy Gifford, who's here today, as well as our other co-authors, Eileen Ellis, Amy Lashbrook, and Mike Nardone, and the amazing team here at Kaiser, led by Libby Hinton, with Maria Diaz and Marina Tian. Together, they really worked tirelessly through the summer and the fall to compile all the information into a report that tells a story about what's going on in this complex program. We also want to thank Jim McAvoy at HMA, who does the data that we use for the report, Salem Magustu, as well as the production, communications, IT, and building staff here at Kaiser that help put the report together and help organize the event and the logistics for the event. So clearly, this is a huge team effort to get this report out. And finally, before I move on, I just want to take a minute to recognize Diane Rowland and Barbara Lyons, who had been here for every previous release of this report. Diane has transitioned to an emeritus status here at Kaiser, but we congratulate her today especially as she's receiving an Alumni Achievement Award from Wellesley College to recognize her outstanding achievement in national health policy. We in this room and those of us who are interested in the report know that there's no one who has contributed to Medicaid policy over the years more than Diane. And I think she would want us to remember that as we look at all these numbers and the charts and the figures and statistics, that there are people behind all of these policy initiatives that we should remember. So with that introduction, I'm going to jump into the main event and talk about the findings from our reports and then move to our panel discussion. I am not going to go through the bios of all of the folks who are participating on the panel, but let me just say it's a really remarkable group that we have up here, true experts that have so many years of experience with the program, and I'm really looking forward to our discussion today. So if we can move to the slides in the packet, we will get started. So today we are releasing 2 reports that draw on the findings from our 19th annual survey of the Medicaid directors. We are in the field from June to September talking to all of the Medicaid directors in the states as well as the District of Columbia. The information is compiled into the 2 reports that are released today. First, a report that looks at national trends in spending and enrollment. And then the second report, the policy report that we released jointly with NAMD, provides a detailed look at the policy and programmatic changes in the Medicaid program that are going on across the states. In Washington, D.C., there is certainly no shortage of national news related to health reform and many other issues, but the report really does provide a view from the states, and I'm really excited to jump into the findings and talk about what the states are doing. The much shorter report that we released today looks at this Medicaid trends in enrollment and spending. As states were finishing fiscal year 2019 and starting fiscal year 2020. After peaks in enrollment and spending following the implementation of the Affordable Care Act, data show that enrollment actually declined in both fiscal year 2018 and 2019, and states are expecting flat growth headed into fiscal year 2020. On the spending side, largely driven by the enrollment trends, there was slower spending in Medicaid spending growth in fiscal 19, but for 2020, states have budgeted for more typical or historic spending growth in their budgets for the upcoming fiscal year. We do ask states what factors are driving these trends. States reported that the stable economy and better economy was the primary driver that was slowing enrollment declines, but states also pointed to a number of changes related to renewal processes and enhanced eligibility verifications, such as periodic data matching, as contributing to that slow enrollment growth. In addition, a few states pointed to a chilling effect that might be a result of the public charge rules and other policies targeted towards immigrants that might be slowing enrollment growth. States also, on the spending side, reported that rising costs for prescription drugs, as well as long-term care spending, provider rate increases, so a number of states are targeting increased reimbursement rates, as well as the acuity and case mix of enrollees are factors that are contributing to spending growth. We ask states to report what's happening with their state spending growth as well. So typically state spending and total spending grow at similar rates, except when there are changes in the federal match rate. So in state fiscal 2018, that was the first state fiscal year where states had to start contributing a portion of their share of the costs for the ACA Medicaid expansion. In that year, we saw that spending growth slightly outpaced total spending growth. However, even if states continue to bear a little bit more of the share of the cost for the expansion, which goes up to 10% by January 2020, average state spending growth across all the states is expected to grow at a slightly slower rate than total Medicaid spending. So with that, quick overview of what's happening on the spending and enrollment trends. I'm going to turn it over to Libby and then to Kathy to dive into the policy findings, and then I look forward to our discussion.
Thanks, Robin. So now I'm going to turn to some key findings from our main policy report. As usual, we won't have time to cover all the details in the report, so we encourage you to download the report from our website to look at the amazing array of Medicaid work underway across the country. As in the past, the report addresses policy changes in 2 years. It addresses changes in fiscal year 2019, and it addresses policy changes planned or implemented in fiscal year 2020 across a variety of policy areas, including eligibility, managed care and delivery systems, benefit changes, long-term services and supports, provider rates, and much, much more. First, I'm going to turn to eligibility. So as was the case in last year's report, changes in eligibility policy, both expansions and restrictions, are a primary storyline in this year's survey. It's also a complicated story, so bear with me. On the expansion side, in Maine and Virginia implemented the ACA Medicaid expansion in fiscal year 2019. Another 3 states, Idaho, Nebraska, and Utah, adopted the ACA Medicaid expansion through 2018 ballot initiatives. However, full implementation has been delayed in all 3 states as they seek waiver authority to implement the expansion with different policy elements, sometimes using multiple steps and sometimes in phases. However, even with waivers still pending, Idaho plans to implement the expansion in January 2020. The ACA expansion debate also continues in some non-expansion states, including North Carolina, where expansion has resulted in failure to pass a budget in the state, as well as efforts driven by the governor in Kansas, and a ballot campaign is underway in Missouri. On the flip side, on the restriction side, 7 states in fiscal year 2019 and 6 states in fiscal year 2020 are implementing policies counted in our report as eligibility restrictions because they could restrict enrollment. So this year, the most common restrictions reported were for work or community engagement requirements, retroactive coverage changes, and lockout periods. These changes all require Section 1115 demonstration waiver authority. So far, the work requirement approvals have been vacated by the courts in 3 states, in Arkansas, Kentucky, and New Hampshire, although an appeal is currently underway. Litigation challenging Indiana's work requirement was also recently filed. So in the coming months, we'll be watching for the results of the work requirement litigation. We'll also be watching for the outcome of pending work requirement waiver requests in 6 non-expansion states. So states that may have lower levels of eligibility based on income for parents and caretakers and who exclude childless adults from their programs. CMS action on these waiver requests will have important implications for states seeking to adopt similar policies. I'm now going to turn to talk about managed care. Managed care, especially capitated managed care, remains the predominant delivery system in Medicaid and continues to grow. As of July 2019, there were 40 states contracting with MCOs, up from 39 states in 2018. In fiscal year 2019, Arkansas implemented a capitated managed care arrangement for a targeted population. In fiscal year 2020, North Carolina will join the ranks of MCO states as they plan to launch their MCO program next February. While managed care has continued to grow, the managed care penetration rate across Medicaid eligibility groups has remained relatively stable. As you can see on Figure 7, of the 40 states, MCO states, as of July 2019, 33 of those states enrolled 75% or more of their beneficiaries into MCO arrangements. This includes 9 of the 10 states with the largest Medicaid enrollment, accounting for over half of Medicaid enrollment in the country. Consistent with our 2018 report, children are most likely to be enrolled in MCOs, while seniors and people with disabilities are least likely to be enrolled in MCOs. In this year's survey, we asked questions to learn more about which performance metrics states are using in their MCO quality incentive programs. Specifically, we asked about performance metrics linked to pay for performance or penalties, capitation withholds, and auto-assignment algorithms that include quality factors. We learned 31 of the MCO states are tying MCO incentives to chronic disease management metrics. 26 states are tying MCO incentives to perinatal or birth outcomes, and 24 states are tying incentives to mental health metrics. These findings are not surprising, given the chronic physical and behavioral health needs of the Medicaid population, as well as the significant share of births financed by Medicaid. In this year's survey, we also found that states continue to leverage MCO contracts to promote and address strategies to address social determinants of health. The most commonly used strategies, as you can see on the slide, were requiring MCOs to provide enrollees with referrals to social services and screening enrollees for social needs. Some states also require MCOs to track the outcome of those referrals or employ community health workers. In all, over 3/4 of MCO states used at least one of the strategies listed on Figure 9 to try to address the social determinants of health. More MCOs are also requiring health plans to replace fee-for-service provider payments with alternative payment models, or APMs, that reward cost-effective, high-quality care. In 2020, 24 MCO states will include APM targets in their MCO contracts. A number of states also reported MCO contracts related to requiring MCOs to participate in a state-directed value-based payment initiative like ACOs or episodes of care. And a host of other states had requirements around MCOs developing an initiative within state-specified guidelines. For example, Tennessee requires its MCOs to participate in the state's episodes of care, patient-centered medical homes, and behavioral health home initiatives, while Utah plans to require its MCOs to adopt a value-based payment strategy to address hypertension. I'm now going to turn it over to my co-author, Kathy Gifford, who will continue with the findings from the report.
Great. Moving on to benefits. Consistent with trends that we've seen for 8 or 9 years, more states are adding or expanding their covered benefits as compared to making cuts. So same story for several years now. The most common benefit enhancements reported were for mental health and substance use disorder services, and a smaller number of states also reported benefit expansions related to dental services, pregnancy and postpartum services, such as like a home visiting program, and dental. Dental always seems to show up every year, both plus and minus. And the most common services, the most common benefit reduction, in fact, was adult dental. Now, we also this year for the first time, well, not for the first time, but maybe for the second time, we ask about IMD services. That's services in an institution for mental disease. This has historically been excluded from coverage in Medicaid by federal law. But we found that in fiscal year 2020, 43 states plan to cover IMD services using one or more of the flexibilities that are now available, and that would be managed care, and we'll explain all this in the report, managed care in lieu of authority, Section 1115 waiver authority, or a new state plan option made available by the Support Act. Pharmacy remains a cost containment focus for many states, due in large part to the rising costs associated with specialty drug products. Again, not new this year. 24 states in fiscal 19 and 26 in 2020 reported implementing new or expanded pharmacy cost containment measures, including efforts to increase PBM transparency and the impact of spread pricing in managed care. Initiatives to implement value-based payment contracts linking pharmacy reimbursement to patient outcomes for certain high-cost drugs, and a variety of other strategies. For the fourth year, we again ask questions to gain a better understanding about how states are using Medicaid to help respond to the nation's opioid disorder epidemic. All states reported having specific opioid-focused pharmacy management policies in place or planned for implementation, things like point-of-sale safety edits, quantity limits, other utilization controls. We also learned that a number of states were planning to make pharmacy benefit management changes in order to come into compliance with the Support Act requirements, including expansion of point-of-sale safety edits, updating drug utilization review activities, and amending MCO contracts as needed to include new requirements. Finally, we learned that states are continuing to take steps to increase access to medication-assisted treatment, although a number of states reported access challenges, especially shortage of waivered providers and rural providers in particular. Turning to long-term services and supports, I'm going to call that LTSS, just to save a few syllables. As has been the case for practically the entire history of this 19-year survey, the vast majority of states reported actions in both fiscal 19 and fiscal 2020, and using a variety of tools to expand the number of persons served in home and community-based settings. The most commonly cited strategy was using an HCBS waiver, home and community-based services waiver, or a state plan option, and nearly all of the 25 states that do capitated managed long-term services and supports, almost all of those states reported building rebalancing incentives into those MLTSS contracts. We also asked states if they were taking action to address the challenge of finding and retaining LTSS direct care workers. 25 states in fiscal, more than half the states, 25 in fiscal 19 and 27 in fiscal 2020 reported increases in direct care worker wages in Medicaid, which is a notable increase from the 15 states that reported wages increases in 2018. In addition, 15 states in fiscal 2019 and 10 in fiscal 2020 reported on other workforce development strategies, including recruiting, credentialing, and training initiatives. We also asked about housing-related supports, which remain an important LTSS benefit, even though states are anticipating the eventual expiration of the federal Money Follows the Person, or MFP, grant funds. 37 states reported having at least some housing-related support services in place in fiscal 19, and 13 states reported plans to add or expand these services in 2020. Now, Congress has recently acted to provide a time-limited extension and about another $254 million for the MFP funds. So the longer-term future of this program remains a bit uncertain about how long it's going to last and when it's actually going to end. But anticipating the eventual phase-out of this program, a number of states reported transitioning their MFP services to other state plan or HCBS programs. But a greater number of states reported that they expected that some cuts would probably be needed services would need to be discontinued when those funds ran out, including some housing-related services. So every year we ask states about their top priorities for the year ahead and learn about a wide variety of high-priority initiatives underway across the country. While every state is unique, common themes do emerge. Consistent with past surveys, a majority of states reported that improving quality and focusing on health outcomes are a key priority, including, for example, initiatives around managed care, value-based purchasing, initiatives to address the social determinants of health, efforts to transform behavioral health systems, and programs focused on improving maternal, infant, and child health. Nearly a third of states reported on high-priority information technology projects, and about a quarter of the states reported that dealing with a Medicaid budget or fiscal challenges was a top priority. A few of these states were particularly focused on the challenge of dealing with high-cost prescription drugs. Now, a number of states highlighted priority Section 1115 demonstration waiver initiatives, waiver amendments, or waiver renewals. And as you probably know, these waivers require significant administrative time and resources to develop and to negotiate with CMS and implement. They often require system changes. They maybe have to contract with support vendors, and they have to often coordinate with their MCOs. It more than likely requires member and provider outreach, education and engagement, and regulatory changes and other administrative tasks. Clearly, a very heavy lift for the states that take on this challenge. Finally, other common priorities cited included continuing to tackle the opioid epidemic and preparing for an aging population. As always, it is an exciting and challenging time to be a state Medicaid director, and I really look forward to hearing from our panel today. But before I hand it back to Robin, I too want to thank my co-authors on the report, Eileen Ellis, Amy Lashbrook, Mike Nardone from HMA, and Robin and Libby and Maria and Marina here from Kaiser Family Foundation. What a great team. What a great project. I so much enjoyed it. Appreciate the opportunity to do it again this year. And also want to extend my thanks to the Medicaid directors and your amazing staff who answer our emails, return our phone calls, fill out our surveys, and are so nice. So thank you.
Okay, well now it's the good part. Because there's so much information in the report, and I think it's just so valuable to be able to hear how all of these findings translate to what's actually happening on the ground. So as I mentioned, we are so lucky to have three really seasoned and experienced Medicaid directors with us to talk about what's happening in their programs. So I just want to open things up and ask if each of you can maybe talk about what's happening with your spending and enrollment trends as you reflect on the national trends, and maybe just highlight to tee up some of the continued discussion of what are the key priorities that you're working on in your states. Go down the line.
Sure. First of all, I do want to thank Kaiser and AMD and the survey as much as our staff, are willing to talk to you. The survey and its results are really utilized at the state level every year. We look at the survey and we look at what's going on nationally, and it's a good way for us to kind of consult with our counterparts about what's going on in their state and kind of learn from each other. So thank you guys as well. So, with enrollment trends, West Virginia is much like what was presented. We are seeing a downturn in enrollment. At one time, our enrollment post-expansion was as high as 535,000 members. West Virginia is a state with 1.8 million total population. Our state in general is losing population. We're one of two states that have consecutively lost population for the past few years. Our enrollment as of June was down to 505,000. We do think it's kind of leveled out. We think that we are at that stability point with regards to enrollment. Our enrollment losses are around our expansion population and our children. But with that 505,000 and total enrollment is going down, but we are seeing an increase in our foster care enrollment and an increase in enrollment of children who are at risk. So that number is actually more than doubled over the last 3 years. That's much due to the opioid epidemic, and West Virginia is unfortunately leading the nation in removing children from the home per capita. And so a lot of our focus is, while our enrollment's down, our spending is up on that particular subset of population and really focusing on initiatives for our foster care population in order to give them good quality care and in-home care versus institutional care.
Great.
There's the button. I want to echo too what Cindy just said about how valuable this survey is to just our Medicaid programs. We refer to this quite often and helps direct us to states in terms of how they might help us. We states talk a lot among ourselves in terms of how we support each other. State of Washington, overall, the population of our state is about 7.2 million lives, and about 1.8, maybe slightly less, are enrolled in our state Medicaid program. We spend about $15 billion a year between the federal and state share in terms of our program. Our trends have been relatively flat, although we've seen a little bit of decrease in expansion, probably related to the economy. And TANF also in terms of drops, but certainly overall our trends have stayed relatively flat. And that's been true about our spend too. It's been relatively flat. The last couple of years we had a spike, and then the last couple of years it's been down, and certainly in 2020 the trend is looking to probably be something less than 2%. I think in part too with our enrollment, we've added staff to do more data mining, that sort of thing, to make sure that we are only serving individuals that are truly eligible. So we've done a lot of work on that. You also mentioned just some of our key issues, and right now, certainly, just as been said already, managing costs, improving quality, improving access. You'll hear more about that from me later. Workforce issues. Rural health's a big issue. Behavioral health, I think, is really top of mind in many ways. And our state just recently, over the last about little less than a year and a half, the behavioral health, community-based behavioral health delivery system now sits in the Medicaid program. It used to sit in a different agency. It's now come to our agency and sits within Medicaid. So just that coordination and collaboration with the behavioral health delivery system, I think, has certainly brought much more attention to that and how we deliver services.
Thank you for having us. We think the budget survey is helpful because it allows us all as an executive staff to get a better understanding of some of the integral parts that drive certain parts of the program that otherwise we may not see. So we appreciate the opportunity as well. We are a program in Tennessee that is roughly 65-35 federal state funding. And we have seen relative flat spend over the last few years, but there has been some fluctuations related to enrollment volatility that we've experienced really since starting in 2014. And also some pretty key cost drivers for us have been specialty pharmacy year-over-year increases, double-digit percentage trends have been pretty high. We've also seen a higher uptake of mental health services in Tennessee. Both of those things are things that are on our radar. We also have some value-based approaches that are trying to address that and try to, especially on the mental health side, meet people where they are and try to get them way upstream instead of waiting until they get into crisis. So that's some of the things we're looking at, which is kind of a preview of what we'll talk about later. We've also recently launched in previous years some value-based purchasing arrangements around primary care and mental health. And now that we're in year 3 and 4 of those, we're starting to see better uptake and better integration and better utilization of those services, which is a good thing. So those are also some additional cost drivers. And then generally related to enrollment, we've got acuity mix changes that are, I wouldn't say they've been hard to map, but they've kind of been all over the place the last few years. As we saw our enrollment peak, I think all-time peak at the end of 2016. So from January 1st of 14 until the end of 2016, we went from a program that served approximately 1.2 million Tennesseans every year for more than a decade to almost 1.6 million. And then we went from that, we have gotten down to about 1.4 million. We're just over 1.4 million. And so as you can see, the number one significant driver of that was implementing a brand new eligibility system and pausing redeterminations and renewals for basically 2.5 years. So you see that happen, and it's kind of difficult to plot what is specifically related to your driver of cost. But we do know that there's an acuity mix change that's happening as well.
Great, thanks. Just to pick up on some of these issues, and we'll come back around to many of them, but there is definitely, as you mentioned and throughout the report, a big focus on quality, value, outcomes, in addition to addressing social determinants of health. We also found another theme in the report is additional focus and attention to addressing maternal mortality and improving birth outcomes. And I'm wondering if you could just share some of what's going on in your state related to this, this range of efforts.
So in West Virginia, a couple things. We were one of the states. We've expanded our pregnancy coverage. We were before at 150%. We're now at 185% for pregnancy coverage. We also have a very intensive LARC initiative. We directed all of our MCOs to basically follow the LARC initiative, pay it outside of the bundle, and those kinds of things. And we've also had a high focus on, because of the opioid epidemic, on mothers with SUD. We have applied for the MOMS grant. We're anxiously awaiting to hear the results of that. But we have already have what we call maternity health homes. It's not under the Health Home Authority, but we've partnered with our Bureau for Behavioral Health and have community engagement workers working in the maternity health homes for mothers who also suffer from SUD in order to improve those birth outcomes for those children. And then that community engagement worker also follows that family a year postpartum in order to make sure that we have continuity of care, even though sometimes, most of the time, the mother falls into the expansion. There are rare occasions when the mother does fall off post the 60 days, but we still have the community engagement worker working with her.
So just in terms of some of the various initiatives that we have going on in Washington, and we have a number, so I'm just going to really quickly hit some of the high points. But we have a delivery system reform 1115 transformation waiver. We were one of the last states to get one of those waivers under the Obama administration. It is really reflecting three major initiatives or three major activities. One is really focusing on Medicaid transformation at the local level through our accountable communities of health, these cross-sector organizations that really help advance practice transformation and looking at local solutions for a variety of related health-related issues. Our foundational community supports, which is supported housing and supported employment, and a real focus on starting to really bring a focus on our social determinants of health and focusing on really the highest risk populations that that are vulnerable for losing housing, losing employment, or being able to just gain it in the first place. Also a program called Family Caregiver Supports, which helps family caregivers that are caring for loved ones in the home and helping them and providing supports around that so that they're able to maintain that individual in the home and either reduce their time on Medicaid, or perhaps not apply for Medicaid at all. A big initiative in our state on behavioral health integration. We're bringing all of our behavioral health services into within our 5 managed care plans. Big managed care state, most of our enrollees are in managed care. And so we're about 70% complete with that activity, and by January of next year, we'll be 100% of our Medicaid enrollees will have their behavioral health provided through their managed care plan. And we're already seeing for some of we have some early results in terms of decreased ER, reduced recidivism back to state hospitals, and some really positive feedback about improved care coordination for folks. We're expanding SUD services, and particularly with a focus on pregnant women, and also medication-assisted therapies to really get more providers engaged in that. We've just entered into an agreement with AbbVie in terms of hepatitis C and how we will be looking at being as close to eradication of hepatitis C in our state as one can. But negotiating a favorable contract with them, and they will also be providing physician education and support and doing community outreach to actually engage individuals to be tested for that. Our health home program, continuing that program. We have been very successful. We've over the 4 years of that program, we've saved Medicare $160 million, and we get to share in savings in that. And then in addition, I could probably go on with many things. Also, the same thing with LARC, trying to do more work with LARC and get it out there with our families and help space pregnancies. But always, what are we doing in terms of quality of care, alternative payment mechanisms that we're working with our plans, and a heightened focus on program integrity.
It's interesting. I'm taking more notes about what they're doing so we can go back to Tennessee to do it. That's good. Couple things. We've got a pretty robust value-based purchasing program in Tennessee. We launched in 2013. Started with episodes of care program that is not a bundled payment. It's a retrospective review. So we brought clinicians in and figured out, for example, what are all the codes and what are all the services that are needed and what are all the ancillary services needed for a total joint replacement. And then we have these pretty complex risk adjustment algorithms, et cetera. And then at the end of the year, we compare the providers that are the most responsible and the ones that have the best opportunity to steer folks against all the rest in the state that are doing the same sort of thing. And then we tie reward payments to quality, so quality outcomes and other types of quality. And then we spend a lot of time and spend a lot of money through some SIM grants and building some infrastructure on training and sharing of best practices among the medical community, which has been pretty helpful. Obviously, we've had a lot of buy-in across the board. It was a stakeholder buy-in process, but there's also, some friction there. So we bring everybody back together every year. We review what's worked well, where there's some potential opportunities for improvement, and then we make those changes based on those. So that's been pretty helpful to us. But we've then kind of gone into more of the health home approach. And so we had always, of course, assigned new Medicaid enrollees in Tennessee to a primary care provider, but what we weren't seeing the type of investment either from the kind of holistic view of the person or even from the buy-in from the member to the doctor. And so what we tried to do was address that through building a pretty robust medical home program that we now have about a third of our members involved in that are actively engaged. So far, what we can tell, the providers love it, the members love it. And we think we're starting to we're going to be releasing a report by the end of the year talking about the quality and financial outcomes of that, which have been pretty eye-opening in just 2 full years of those programs. And then we also have done a very similar program with behavioral health. We call it Tennessee Health Link. We go to our community mental health organizations and basically establish a health home there for the folks that have some severe behavioral health challenges from time to time. And we've got about 75,000 of our members who are actively engaged in that process. And it's been a really great opportunity for us to work with those providers. It's been a great opportunity for us, obviously, to have some really good investment on the member side there as well. There's a lot of trust with those members and those providers. And so we think that's really kind of been a win-win-win. We actually had our Association of Mental Health Organizations in Tennessee put out a press release earlier this year bragging about the program. And we were able also to use that and to utilize some grant money to help them kind of transition certain parts of their practice. And we heard that from them loud and clear that they want to help us with this, but they need some financial assistance to kind of get from point A to point B, and we're able to do that, and it's been extremely successful. I think the outlook there is really good. A couple of other things we've got, and we're kind of in year 3 of our new chief medical officer, and one of his priorities when he got to TennCare was to focus on EPSCT screening rates. And we have seen a steady, I think we're in either year 3 or year 4 of a steady rise in EPSCT screening rates. It's extremely important to us in that regard. We also, with West Virginia, are kind of at least part of our state is on the front lines of the opiate epidemic. And so NAS births have been a pretty big deal for Tennessee for quite a while. And we are seeing now 2 years in a row a reduction in those diagnoses, which is great. We've got a pretty comprehensive opiate strategy that includes a lot of things, but one is for the first time we actually built a specialty network requirement into our MCO contracts so that they have medication-assisted therapy providers across the state. I think we have just shy of 90 across the state right now. It's probably not enough. But they're in some areas, but in other areas there may be a few more than we need. But either way, it's a program that's worked well we're starting to see some pretty good feedback there, and we're also working with that provider group to understand what are the quality metrics we really need to be incentivizing. The last couple of things I'll talk about is maternal mortality is something that we've been struggling with as a state for a while as well. We've got a pretty robust consignment program for LARC, IUD, that we really tailored to the needs that we heard from the provider community and from our members who are seeking access to that service. We try to remove some barriers so that it's just you can it doesn't require 2 doctor visits, for example. We kind of front the payment of the LARC device on the front end. It's not dispensed to any one particular person, and then we can have it there either with the delivery or at a different setting after the counseling, et cetera. So that's been also something that's been pretty well received by our population, our membership. And the last thing is that we've got 8 birthing centers now, large birthing hospitals that are investing pretty significantly in counseling on spacing, interval spacing for births. So that's also been helpful, and I think we'll see some long-term impacts there positively.
Wow, that is a lot going on. I want to shift a little bit to talk about what's going on with long-term services and supports. Certainly, this is always an issue, I think, for Medicaid programs. This will become an increasingly more important issue as the population continues to age. And I know each of your states are doing things, innovative things related to serving the duals population as well as service delivery around long-term services and supports. So I'm just wondering if you can talk a little bit about what's going on, in terms of those services. I'm not sure, Mary Ann, you want to start on this one since we could switch up the order.
Sure. I think one thing to mention, the long-term services program sits in a different agency. So there's a tremendous amount of collaboration between our agency and that, while it's still under the we support them as a single state agency, but much of the program design and their work rests there. But the areas that I think are really important in the state of Washington, we've been a rebalanced state for a very long time. So the fact that we have about 85% of our individuals are served in a home and community-based setting and about 15% in a nursing home. So we've had the opportunity to reduce that nursing home footprint, since the 90s. As I mentioned earlier about our health home program, that health home program and much of the savings, of course, is around the dual eligibles. So those are individuals that are often served in our long-term care settings or could be. So that program has been an incredible support to our community, AAAs and others, to bring more care management to that population. And as you can see from the kinds of savings that we've accrued to Medicare, primarily on reduced emergency room use, reduced hospitalization, and reduced nursing home, that we've been able to save a significant amount of money. So that's probably one of our really keystone programs is that health home program. And then, as I mentioned earlier, as part of our waiver, the kind of supports that we're providing to families that have these family caregivers, and and really importantly, one of the programs is to help families so indeed they can either perhaps not apply for Medicaid or reduce their footprint on Medicaid, and those programs don't apply to a state recovery, which is often really important to families that they don't want to, they want to be able to keep their family home and not give it up in terms of having to pay back Medicaid for expenditures that have happened while a family member's in a long-term care setting. So those have been sort of the focus for us in our long-term care programs over the last few years.
So we've been a managed LTSS state since 2010. Had really good success rebalancing. I think we're close to around a 60-40 split of nursing facility to folks who are getting services in their home or community. And we've got a really good partnership with our nursing facility industry. We actually recently began the transition of a quality-based reimbursement structure for the nursing facility payments and kind of moving away from the age-old kind of cost-based reimbursement piece. And they, came willfully to the table on that because they get that. They get that quality matters. and it becomes a differentiating factor among their membership. And so we're excited about that and continue to work well with them. So we've got a good kind of rebalanced group. There's more room obviously that we could go, but we also have a good relationship with our nursing facility industry, which I think is speaks a lot to their leadership and also to kind of their vision of what Tennesseans need. So we're excited about that. We recently, I guess we're about 3 years in now, we had all of the services for individuals with intellectual and developmental disabilities in a 1915 waiver. We actually have 3 1915 legacy waivers in Tennessee. And we actually have added services to that population now in our 1115 kind of global waiver. So we now have about a quarter, I guess, of the total number of individuals with IDD in Tennessee that are now getting services in an 1115 waiver. And where we're going with that, we call it employment and community first choices, and it's been really remarkable. We have 5 groups, 5 offerings, 5 groups of folks, of types of services that we provide. And the focus is, we really built this based on what we were hearing from the families and advocates in Tennessee. And Patty Killingsworth and her team did this, and we spent, I think, 18 months going around the state on a roadshow around where we want to go and what we want to do, and we designed the program to meet the needs of the families in our state. But long story short, we offer more than 14 different types of services, a focus on community integration, independent living, and also on workforce preparedness and getting jobs in competitive jobs, not shelter workshops. And so the stats that I remember and that I love is roughly a third of our workforce aged folks in the ECF Choices program are all working, I think on average just shy of 20 hours a week, maybe a little bit higher than that now, all in competitive jobs, and the average hourly wage was close to $9 an hour, so maybe just a little bit shy of that. So those things are good. I mean, it's early. There's still a long way to go there, and I think that for us, we actually have a waiting list of almost 8,000 people that want to get services in that program. And so one of our focuses going forward is trying to figure out how do we do that, how do we right size that. We obviously would love to provide the services to all the folks because we love the program, but we've got to continue to build provider capacity because the workforce shortage for direct service providers in Tennessee is almost crisis point. And so we have been utilizing in the last 2 years, have been developing what we believe is a premier workforce competency-based education training program that actually has been endorsed or will be endorsed by some of our, we call them TCATs in Tennessee, but effectively 2-year colleges. That basically 18 semester hours, and along the way you kind of earn your badges along the way of getting a certification, and each set of badges is worth additional per hour reimbursement. And so we think that that's one way to do it. There are other ways to do it as well, but one of our focuses is really trying to grow and invest in the workforce in Tennessee. And our current governor, of course, it's a big issue for him. We're very, very rural, despite Nashville and Chattanooga, we're a very rural state, and so there's a lot of opportunity there. Last thing that I'll mention, I guess, is that we've also we spend a lot of money on duals, and so there's a big opportunity, and the outcomes of duals aren't mirrored or even really kind of pinned at all to the outcome of our Medicaid-only folks in LTSS, and so we think there's an opportunity there in the near future to really go after that. And really try to drive better outcomes for those members. And I think we're in a place now where we have a good relationship with all of our home health agencies, but also our nursing facilities, and we think that we'll be able to be well positioned in the next few years to really try to drive better outcomes there.
So in West Virginia, we have 3 1915C waivers, an IDD waiver, age and disabled waiver, and a TBI waiver. Our IDD waiver does have a wait list of around 1,200 individuals. We have been able to, through some cost containments and changes that we made in our waiver program to right size the waiver program, take several hundred people off that wait list as of recent. We have 508 ICF beds in the entire state of West Virginia, and all of our ICF beds are 8 beds or less. So we don't have large institutions left in West Virginia for our IDD individuals. On our age and disabled waiver program, we were able to, at one time we had a wait list, we were able to lift that wait list. We've had a moratorium on our nursing nursing home care for over 15 years. So we have around 10,000 nursing home beds in the state of West Virginia, but that doesn't grow. However, we're not right sized when it comes to payment with regards to home and community-based services versus our institutional care services. We are looking at nursing home payment reform in the future. Our long-term care services is one of the services that are carved out of our managed care environment. Eventually, we are looking at how to move those services into our managed care environment. We're just not there yet. We just recently moved our SSI population into our managed care environment, and one of the things that we have been able to do with our MFP program, we had some transitioning services and different services in our age and disabled waiver that we went ahead and added those to our waiver program and instituted those because those were very effective in transitioning individuals from nursing home care to the home and community-based services.
Great. I want to, before we open it up for questions, I just want to do one lightning round maybe to wrap things up. There are certainly so many other issues going on related to prescription drugs and other issues, but I would just say looking ahead in this current fiscal year and sort of beyond, maybe just wrap up with what sort of keeps you up at night because you're really worried about it, or something that you're really excited about, you know, what do you see in this fiscal year and beyond? And I'm sure we haven't touched on the Tennessee proposal. I'm sure we'll have some questions on that. So I think that's probably in your list of things that are major focus.
There are a lot of things that keep me up at night, not all work related, but we'll talk about block grant. So we are about to submit an amendment to our 1115 waiver. It'll happen in November, and we are asking CMS to reimagine the federal state funding mechanism that we currently enjoy. And the idea is that it is not, I want to make sure we're really clear about this, this is not a traditional block grant approach. This is, you can call it a modified approach, maybe a hybrid approach, but there are three key elements to it. There is going to be a calculation that effectively, this isn't exactly what happens, but effectively from a conceptual standpoint establishes what a floor of federal dollars coming into Tennessee would look like. So that's kind of more the traditional block grant piece. It doesn't go down if our enrollment goes down. And then if it goes up, it's indexed to inflation in our enrollment. So it's almost kind of got a little bit of a per capita cap notion to it in that regard. The third piece of it, which is really the vital and the key element and is unique to Section 1115 demonstration waivers states like Tennessee, is it looks at the concept of budget neutrality. And it looks at where the state comes in from an actual spend in any given year and compares it to what the CMS projection is for budget neutrality in that year. So let's just do some easy math. So if the projection was $15 billion of spend in Tennessee in a given year if we did not have our 1115 demonstration waiver, and we came in and we spent $10 billion, which, by the way, those numbers are different in reality. But the difference there is $5 billion of spend. Now, I told you earlier we're effectively a 65-35 split of federal and state funding. So a third of that difference, a third of that $5 billion represents state dollars that we aren't spending. But the other 2/3 of that represents federal dollars that we've saved, and we don't really get any benefit from that. Our hypothesis is that the federal government spends more money in the current financing structure in states who spend more money and spends less money in states who manage their program well and spend less money. And so what we believe is that the flip should be true, that if you find a state who does well, who has a 95% satisfaction rate among its members, like Tennessee, who routinely underspends these budget neutrality projections by billions of dollars, like Tennessee, and who has virtually every licensed provider in the state who participates in their Medicaid program, like Tennessee, and then has very far-reaching value-based programs with outcomes to match it, like Tennessee, we think we should be rewarded. In addition to that, the specific request is that if you look at that difference between the budget neutrality projection and what we actually spend, look at the federal share of that, and we're asking for the federal government to give us 50% of that money to our state for us to spend without first having to come up with state match. So in a business arrangement, these are shared savings. They're pretty common. We actually see some of that in the managed care environment where MCOs will go to providers or to some case management providers and say, we've got a really risky population. The volume of people may be small, but there's a lot of risk there. Can you help us? And we will pay you your underlying codes and reimbursement, but whatever amount the money that we save, we'll split with you. We think this is a good approach. Effectively, what we are doing is asking CMS to hold Tennessee to the same standard that Tennessee holds its MCOs and providers to. We think that makes sense. We have said, and we are confident, that this will bring more money into the state of Tennessee, not less. We have committed not to limiting eligibility. We've committed not to limiting benefits, and in fact, specifically committed to using the money, all that additional money, on our program, on our program through targeted benefit enhancements to who we currently cover and where we can and when we can, covering new people. In addition to that, we've also committed on the front end not to skimp and save, I think is kind of the terminology, where we may get 9 figures of additional federal dollars coming into the state in a given year, but we reduce how much money on an ongoing basis from our current state funds we put to our budget. And we've also committed to keeping that at a commensurate level. I think we use fiscal year 19, and then we'll index that over time. The details of that obviously have to be worked out. I think it's too blunt of an instrument to commit to a current level of funding or some type of percentage because things change. We just need to make sure that whatever we did prior to the waiver, we continue to do, and we're committed to doing that. That's really high level. There's a lot of details there. But the last thing I'll say is that when we get that money, what we would like to be able to do is double down on a lot of the value-based approaches that we have and have some flexibility to spend money on things that aren't just healthcare related. If there are social determinants of health that we believe make sense for our population, a very rural state with the Memphis area and the Johnson City area is very different. Two predecessors ago used to say that you're closer to Canada in Johnson City than you are in Shelby County, and that's true, a 9-hour drive. So there's a lot of differences across the state regionally, and can we invest in those types of things? Can we have the flexibility to do things differently across the state in an additive way, not in a negative way? And can we pay for things that don't have CPT codes or HCPCS codes or whatever related to them? We'd like to be able to do that because we think what that will do is dramatically increase the health outcomes of our population, and I think that will be a game changer for Tennessee. So that's one big thing we're working on.
I think you'll have some questions maybe about that.
So in West Virginia, I agree, there's multiple things that keep me up at night, but I guess the three main factors is pharmacy. We recently carved out our pharmacy benefit. We saw that our pharmacy benefit was increasing at a growth rate that we couldn't sustain when we had it carved in with our MCOs. Once we carved out that pharmacy benefit and we're managing that benefit through state staff and one of our universities is doing utilization management for us, we were able to save $54 million, which is wonderful. But at the same time, we all know there's lots of orphan drugs and things coming onto the market. So we're all very nervous because we don't want to lose those savings. We're utilizing those savings for some of our other innovative programs. The other thing that keeps me up at night, we do have an 1115 SUD waiver, and it has been very successful. We have over 200 MAP providers in the state of West Virginia now. We have several IMDs. Our growth rate opening IMDs at all the different ASAM levels has surpassed our expectations. But at the same time, our SUD waiver really focused on the opioid epidemic and MAT, and we're seeing a trend in West Virginia that I think are probably seeing in other states with the rise of meth. And so while we've focused and poured a lot of resources into MAT treatment doesn't treat meth, and so that's definitely keeping me up at night. And due to our drug epidemic, and I mentioned this before, is our foster care initiative, and that initiative is a specialized MCO that is supposed to, awards should be announced imminently and be on the ground up and running January 2020. At the same time, we're carving in a SCD waiver into that specialized MCO to provide those home and community-based services for that foster care population and that post-adoptive population. And then we're also carving in the ACF services. So not only will the MCO manage the medical services, they will also manage the social services that are typically given through our Bureau for Children and Families. So it's a very unique model, and so we're very excited about it, and it's very scary at the same time because we want to make sure that we do the right thing with these children that are really suffering because of the opioid epidemic and get them back to West Virginia. We have a large number of children out of state, and we want to provide home and community-based services and foster care homes and reunite some of these families that are struggling.
So like my colleagues here, I think we have many, many things that keep us up at night. But I'm going to talk more about something that is exciting to me, or some work that we're just initiating now that hopefully will solve some problems that maybe we won't be staying up as many evenings as I currently am. But it's really looking at the role of Medicaid and what it plays in rural health. And rural health is a big issue in Washington, although you don't necessarily think of Washington as a rural state. We have some very rural and very frontier areas in our state. So we have initiated a cross-sector approach to looking at rural health. So engaging our rural hospitals, engaging our other payers. So bringing the commercial world into this conversation, because we need to find a collective solution to this. It isn't just what Medicaid does in rural areas or Medicare does in rural areas, but also the significant impact of the commercial insurance. Perhaps not as large as commercial insurance might be in a excuse me, in a more urban area, but certainly the conversations that we're having, they have some of the same challenges that we have. So looking at some different payment strategies that could be done across the delivery system, because access and affordability, again, a really big concern for us. And we are concerned about just the survivability of rural health, and then what do folks that live in these very rural areas. I just had the opportunity to go on a rural health tour and visiting a number of rural hospitals, and just the concerns that they have around, what next year will bring, what their provider needs are. We have a new medical school in the state that will be focusing more on training rural physicians in primary care, which I think will help and bring more of that training to rural areas. So folks, if they're trained there, they might stay there. But also nursing, medical assistants, people that will that can serve individuals with behavioral health needs. So what are the kinds of things that we need to do? What kind of payment transformation needs to happen in that area? We're awaiting, CMMI is supposed to be announcing something in the next weeks, months, whatever, that may help support states in rural areas. So we're looking at that really closely. I think another thing that I will say that does keep me up at night is just really the challenges we have with data, with good data, with solid data, with data that helps us make decisions. If we end up in a recession, and who knows what will happen there, do we have the data that will help us, really more timely data, more informative data to make the kinds of decisions that we would need to make if we have to do programmatic cuts, and be able to do that with much better information. So we're putting a lot of focus on that in our agency right now, and we just named a chief data officer, so to have some really significant focus on that. So as we're trying to manage cost, improve quality, bring social determinants into the conversation, we think that's a really important piece for us to work on as we're trying to improve the health outcomes of the folks that we serve. And not just in Medicaid, but our agency also oversees purchasing for public employees, and starting in January we'll be overseeing purchasing for school employees. So other groups that we need to really focus those same areas on.
Great. Well, thank you so much. I want to now turn it over to you all to see if there are questions for anyone on our panel. There are some mics that are floating around, so if you just raise your hand if you have a question, then you could say where you're from and direct
Sure.
your question, that would be great.
Hi, Hannah Katch with the Center on Budget and Policy Priorities. I have a question for Mr. Roberts. First of all, thank you so much for this wonderful panel and report. I was struck by your description of your state's proposed amendment to its 1115 waiver. Given that, in particular, I think we could probably spend another couple of hours discussing the amendment. It's innovative in many ways. But in particular, you just noted, right, unless I misheard, that in the proposal, you're committing not to cut current benefits or eligibility. However, that's actually not specifically what the proposal says. It says that the proposal itself doesn't cut benefits and eligibility, even though it does request unprecedented authority from CMS to make those cuts without federal approval or public notice. So are you now committing to not making cuts to current eligibility or benefits? Are you planning to add that to the proposal, which is in effect a contract once approved?
Yeah, I mean, I disagree with your characterization. I mean, we've been upfront consistently that we aren't going to cut eligibility or benefits. I've been on record as saying it. The governor's been on record as saying it. The legislators have been on record saying they don't want that. So we have been very clear about that piece of it. The unprecedented flexibility request that we're looking for is, as I said earlier, all to be additive, not to be negative. So for example, there's a waiver of comparability or statewide-ness in there that we're asking for. What we want to do with that, and what we talk about wanting to do with that, is we don't cover adult dental in Tennessee. We'd love to, but don't have the money to do that. But we also believe there's a huge value in being able to stop or mitigate oral disease transmission from mom to baby for the first 18 to 24 months of life. So we would like to be able to provide adult dental benefits to mothers postpartum for 18 months or 24 months, whatever the clinically appropriate time period is. But we can't do that unless we cover it for every adult without a 12 to 18 month negotiation with CMS to say, okay, yeah, this is a good idea. Those are the flexibilities that we want. An example of that was that we implemented a medication therapy management program a few years ago, which we all think would be valuable. What we thought it would be valuable, we wanted to test it and see on a pilot basis. And so what we did is spent, I think, almost a year negotiating with CMS the fact that we were starting this new program, the patient-centered medical home approach, and we wanted to have those practices then be able to contract with pharmacists and us pay for the medication therapy management approach. Great idea, seemed like it works. Took us a year for them to say, okay, you can do that. So that's what we want to do. Understandably, it's a bit vague. We're going in for a negotiation, but we've been really clear about what the purpose of that negotiation is. And my experience with CMS maybe differs from others, but whatever flexibility they give us will be very clearly articulated in our waiver, and the limits of that flexibility will also be very clear. And so what I expect to happen, for example, on that will be that if we get that waiver for those stated purposes, those purposes will be included in our waiver, that you have this waiver with only this authority and you can't exceed this authority. I would also imagine, based on, again, our experience with CMS, there'll be quite a few criteria and stipulations around that. So if we did something on a pilot basis, even if we had another public health epidemic in Tennessee, and we wanted to try. We have our state is historically have 3 grand regions: East, Middle, and West. If we wanted to try to pilot 2 or 3 modalities of treatment to address that across the different regions for some period of time to see which one worked best, those types of things are what we want to be able to do. The last thing I'll say is trust me, I'm not asking people to trust me, because we're going to have it clearly articulated, because no one on my staff, and neither is the governor, interested in having a legacy that we've created some type of carte blanche that someone who comes in with the wrong purposes would change that. So we will make sure that whatever those flexibilities are additive, and that they're actually articulated clearly in the waiver to make sure that there is, in fact, transparency and oversight. And if we change that, we have to go back through the waiver amendment process.
Hi, thank you. My name is Carrie Fitzgerald, and I work at First Focus on Children. Recently, the census data came out and showed a drop in children's coverage for the second year in a row. This is after 20 years of consistent growth in children's coverage. What are each of you doing in your states to respond to this? And in particular, Latino children showed a full 1% loss of coverage in their coverage rate. So I'm very curious about how each of you will respond to this in your state.
Okay, I'll go first. So good point, and something that's on our radar screen, has been on our radar screen, frankly, for quite a while. So in Tennessee today, this is an answer to your question, just kind of setting the table. Tennessee today, we are in about month 9, I guess, month 8 of our ACA compliant eligibility system. A lot of opportunities, not only for our members and the public and the providers in particular, but internally, there's a lot of efficiencies there. We're no longer relying on healthcare.gov and then a bunch of kind of wraparound services to make sure that we can kind of fill the holes or the gaps that may have been there. So that's really helpful for us. Being able to get to that point has now allowed us to kind of focus on some of these other targeted outreaches. So some of the things that we're doing and looking at are around the amount that our MCOs can be involved in the enrollment and the renewal process. We are a managed care state, and so it does me no good for folks, whether they're children or otherwise, to come on and off our rolls in the churn, because I can't manage them, but we can't manage their care unless they do that. And so what we are doing right now is I wouldn't say wholesale, but we've gotten a pretty big difference in approach with respect to what we allow our MCOs to do in terms of outreach. Their care coordinators are talking to them regularly. These practices now, either the patient-centered medical homes or our hospitals, have very slick, very easy to use, very quick ways to get people either eligible if they aren't eligible, to check if they're eligible, or to renew if they're in that renewal window. And so one of the things we're doing internally is looking if there are some additional things we can do from a financial perspective for the providers to even help benefit, to help kind of drive that behavior, whether it's incentives or what. We also have some enrollment, I don't know what the actual term is, but some really great organizations in Tennessee that help with enrollment from Medicaid and cover kids up through the whole rung of commercial insurance up to Medicare, and they also know where all the various charitable clinics are. We have a pretty tight net of charitable clinics throughout the state, and so they're really good at being able to tell people, this is how you can go, and this is how you can get paid for going, this is how you can get your care reimbursed, and if you can't, this is how you can go get other care. We're also working with them. A few of them have gotten grants recently, and we're trying to work with them on a data standpoint that allows them to kind of prove to CMS what they are doing and how well they're doing it, so they can continue to get that funding, and then internally looking to see if that's something we can do as well. There are a host of other things that we're trying to do, but yeah, I mean, it is a big deal. I think the last thing I'll say is that while the enrollment process has never been something that's been super easy in Tennessee for decades, where we are now is a place that, and where we've been for the last few years, is all you have to do is make one phone call and you can become eligible for Medicaid. And we've gotten quite a few presumptive eligibility categories and processes in place as well that assist with that, so that if you're in a point in your life where you, like if I have my child in the emergency room, for example, I'm not worried about filling out an application, but we can kind of bridge that gap and then have a longer term solution there. So I'm excited about what can happen in the near future in Tennessee around that piece. But yes, absolutely understand there are also some things kind of outside of our control that are going on that may also be a bit of a disincentive for folks, especially certain populations, from raising their hand and enrolling. But it's a good question.
So thank you for asking that question. I think that there's some challenges around that. At least in Washington, this point, we are looking to see if we're seeing a drop in enrollment. We have real concerns about public charge and those rules in terms of them having a chilling effect on eligibility. So being able to track that and look at that. So that's kind of where we are right now. You know, we've held pretty steady in the last few years with an uninsured rate of around 5%. And the way our programs are designed, where our eligibility cutoffs are, there frankly should be no child in the state of Washington that goes without coverage. And we do use some state-only money to make sure that populations that may not otherwise be eligible for Medicaid, that those kids have a benefit that aligns with Medicaid. But we are watching that really carefully, and also looking at, as I mentioned earlier, about data, so that we can really address health equity related issues more effectively than we probably are now.
So in West Virginia, much like Tennessee, we've worked with our MCOs. So our MCOs can receive a file and know when renewal's up, so a care manager can reach out to that family and remind them to go ahead and get your renewal, because it does no good for them to lapse off and back on. We've also partnered with our FQHCs, our community behavioral health centers, and our hospitals, and allow eligibility determinations in all those facilities as well. And in addition, we are in the process of building a new integrated eligibility system, which is rolling out in different waves that will, our eligibility system now currently has some SNAP benefits in addition to Medicaid, but this will also have a variety of other things in the system, like connections to our Bureau for Child Support Enforcement, connections to our APS, CPS, and all those other bureaus. And so we'll be able to map all those individuals in that system and hopefully do additional outreaches there as well. And as far as the Latino population, West Virginia really has a very small, virtually non-existent Latino population, but we do offer interpreters and those kinds of things when that does occur.
Great. Any other questions?
Hi, Vic Miller, retired fiscal economist. Didn't want to get in front of anybody else, but more than a decade ago, the Medicare Modernization Act put a burden on state Medicaid programs, or states anyway, something called the Club Act, which is now up to about $13 billion a year, where you subsidize the Medicare Part D program without any ability to control the cost of the pharmacies that are being paid through that, as much as you're worried about pharmaceutical costs. How do you possibly manage that?
Yeah, well, that's the issue, right? We can't, and so it's funny. I've heard a few folks that were involved, I think, in that decision at the federal level, a decade ago or so, and kind of touting how great the process is. And I said, yes, because you've offloaded it on the states. So we spend just shy of $800 million a year and 100% state dollars for our entire Medicare share, including the clawback for Part D. One of the opportunities, I believe, that I mentioned to earlier, is around duals. We don't have the ability to coordinate or really do anything as the payer kind of last resort, and sometimes just the payer of premiums for the duals. And so we think there's a real opportunity there. It sounds like there's movement there. Senator Alexander, our senior senator, who's the chairman of the HELP committee, they seem pretty interested in that. I know Levitt Partners is working. There's several different work groups around duals specifically we're participating in, because we think the opportunity is there. And it's not just from a financial standpoint, but it truly is an outcome standpoint. The clawback piece is maybe a little bit different, but the other piece around the care for the full eligible duals, there's an opportunity there for us to really be able to improve some lives if we could just do a few things. And so if we get some flexibility around that, that'd be helpful. We may just potentially save a little bit of money to pay the clawback, though. May not be able to manage that.
Yeah, I think there isn't really much that can be done, and I think a lot like Gabe, we're really, how do we improve healthcare for the duals and make access easier for them to get the services they need, help support them perhaps in DSNP, enrolling in DSNP plans, Medicare Advantage plans, so doing some things to help move them that way. And then there's certainly conversations we've been engaged with a number of other organizations to help think about how do we better serve duals. And of course, our health home programs has been a start for us in that endeavor, and to continue down that pathway.
I really have nothing to add. It's a very difficult, it's difficult to manage, and I think we're all looking at our duals. We do have some DSNPs and different things, but there's not really a clear answer.
Great, thanks. Next question.
Hi, I'm Maria Schiff with Pew Charitable Trusts. Could each of you discuss what you're doing in terms of soliciting applications and eligibility and managed care attachments in the jails and prisons in your state?
I'm happy to start. So we've been working with our jails particularly, and also extending that now to prisons. But one of the things that we're doing is, as someone comes into jail or prison, trying to get them if they're eligible for Medicaid, make that eligibility, then suspend it. so that when they get released, they're on Medicaid, so you don't have to go through the work that, to get them eligible after they go out the door. So that's been a big focus of ours. We now have access to jail release data, so that, and then it's real-time data. So we can inform our managed care plans when somebody gets arrested and goes to jail and when they get out, so that they can start that care management immediately. And those have been successful in reaching folks to make sure that as they're leaving, that they have their medications available to them. But we know there's more work to be done. And so also working with our MCOs to have agreements with the local jails so that they can do data sharing and making sure that that individual has that kind of care coordination upon release. And particularly if they need to get into SUD treatment, that we can do that in a more real-time basis.
Yeah, similarly, we made a change, I think it was 4 years ago now as a state, 4 or 5 years ago, where individuals, when they go to jail, if they're on TennCare, our Medicaid program in Tennessee, they aren't terminated, they're suspended, they're put in suspend status. And we have a big data transfer with not only the state prisons, but the local jails. A couple things. One, when they come back out, then there's an opportunity to go through the redetermination process and stay on the program instead of having to reapply. And two, while they're in the facility, if they have to leave the facility overnight to go to the hospital or whatever it is, especially thinking about women who are pregnant when they go, we actually pay the bill and not the justice system, which is also something that was a state level decision that we made. But our governor, who was elected last year, he's in his first year, has one of his big passions and agendas is criminal justice reform in Tennessee. He's kind of looking at the whole thing, and we're in the process of going through that, and we're at the table with them about this too, because there's some good opportunities around a lot, but specifically around making sure folks who are medications, especially behavioral health and especially SUD, can be able to maintain access to that. And if we aren't the right person to pay for that, then our safety net in the state would be. And so we're at the table trying to figure that piece of it out as part of a pre-release plan that you can go through and do that and prepare folks and have a better opportunity for job and successful life outside.
We're very similar to the other two states. A few years back, we stopped terminating and used the suspension model. We also have a fee that comes from our prisons to let us know when somebody's getting ready for discharge, so we can hook them up, go ahead and work with MCO assignment, and then particularly those with SUD that might be on the withdrawal or MAT. We assure that there is follow-up and an appointment coming out of the jail, so that that all that work is not for naught. So.
Yeah, I would just say that's a question we asked more broadly about in the survey. So we have information in the eligibility section as well as the delivery system. So how states are coordinating, more broadly. There's that information there. I think last question.
So as an organization, we've been interested in the oral health coverage for pregnant women, how that connects to their opioid use, and how that connects to the general welfare of both the pregnancy but also mom, as well as early childhood care use rates. I'm wondering if there's any plans from within your states, particularly, you mentioned this in Tennessee, but in West Virginia and Tennessee, there's very limited adult coverage, and the pregnancy coverage is quite tricky and usually ruled by the So I'm wondering if you guys have any plans or kind of more general ideas for the future?
I can start, although with Washington we do have an adult dental benefit, and it's pretty expansive, but we're just have just started a program specifically for pregnant women so that they get more cleanings, the providers get reimbursed more to see pregnant women, and there's more education components to it. But so we have done some really targeted work specifically for pregnant women, but we do have a fairly robust adult dental benefit.
The only thing I'll add is that our dental benefit is carved out of our MCO piece, so we have a separate DBM. So with respect to, I think that means there's probably not the trickiness of it that you alluded to, because it's a different piece. Again, we don't offer an adult dental benefit except for a small population that we do. And so if woman's pregnant and under the age of 21, there's the full dental benefit there. But it's the adults that we're really kind of focused on. Look, I'm going to record, I'm a fan of that. I think it's extremely important. I think it would make huge strides for us as a state, and we hope that there'll be a pathway for us to do that in the future.
So in West Virginia, we do not have a robust adult dental benefit at all. We do have one of our plans recognizing the outcomes for pregnant women. They do offer it as a value add for those women. We are looking at possible community engagement requirements in the future, and that being an incentive for community engagement for adult dental. But that's about where we're at. And I agree. I believe in adult dental. It's just really a cost factor.
Great. I think we are at our time. So I want to thank everyone for coming to the event and for asking questions. I really want to thank our panel for sharing their perspectives, to Libby and Kathy for managing to get through a 100-page report in less than 20 minutes of findings. And I encourage everyone to download the report. And again, thank you for coming, and have a good afternoon.